Furkan?
Yes,
Hello.
sir.
Right. Shall we start?
Yes, sir. Please start. Up, sir. Start करते हैं, then we'll pose the questions.
Uh, Bismillahirrahmanirrahim. Inna atayna kal kawsar fasalli li rabbika wanhar inna shaniyaka huwal abtar. And we always start with the dua. और आज की दुआ है अल्लाहुम्मा इन्नी अस्अलुका मस्अलुका मिन्हु नबियुका सल्लल्लाहु अलैहि वसल्लम व अऊज़ु बिका मन सअज़का मिन्हु नबियुका सल्लल्लाहु अलैहि वसल्lam. That I pray for all the good things that the Prophet prayed, and I would like to escape from all the bad things, auzu, which the Prophet escaped. So this is our third lecture on dyslipidemia. They are all interactive lectures. In the first lecture by Howard Kazmi, we covered that dyslipidemia as a risk factor, and that was like an eye-opener for all of us through our local data. And then Momin Siddiqui very ably explained the benefits of reducing of the risk factors. And that was an excellent talk, which everybody enjoyed. And the feedback was very good. And today, it is more exciting because we have Momin Siddiqui, who is an associate professor in University of Illinois, and he understands lipidology because he has got a board to him. He passed this board of lipidology. He's the head of non-invasive services. And on the panel, we have got two very distinguished cardiologists. Both of them happen to be interventional cardiologists. Asad Akbar from Shifa Hospital. He has been through Harvard and then trained at Massachusetts General Hospital and then in Mount Sinai Hospital, one of the budding, most aggressive and very sensible interventional cardiologists. And then we have our very dear friend Amber Malik, who is an invasive cardiologist, started a peripheral program and was the head of cardiology in Lahore. So without anything ado, we start with it. We will start as routine with questions, answers, and we will present you questions, answers first. And then after that, we will go for not answers now, but later on. So we will go for the question answers. Now we are starting the question answer, and I will give you about 2 minutes for it. So we are launching question answers now.
All right. Is that working? Everybody can see?
Yes. Yes, please.
All right. So, Assalamu alaikum, everyone. Thank you for inviting me, Dr. Hafizullah, and it's my pleasure to talk to everybody today. And the topic I'll be going over is the nitty-gritty of lipid metabolism, lipoproteins, and dyslipidemias. So I'll go ahead and get right into it. So, a basic outline of my talk, I'll start by going over the basic biochemistry and metabolism of lipids and lipoproteins. I'll try and correlate lipid metabolism to the mechanism of action of LDL-lowering drugs. And I'll talk a bit about the role of serum lipid testing, lipoprotein little a, non-HDL cholesterol, and apolipoprotein B. In the end, I'll briefly go over some important dyslipidemias and their clinical manifestations. I do understand that talking about the basic biochemistry can get a little boring, so I'll try and zoom out from time to time and focus on some practical considerations through the talk. So we already did the questions. I'll skip over them here. All right, so, I'll start by going over what lipoproteins are, right? So the main lipids that are present in our bloodstream are cholesterol and triglycerides. Cholesterol is a steroid. Triglycerides is the second major lipid, and the tri refers to 3 fatty acids bound to 1 glycerol molecule, so that's a triglyceride. Lipids are hydrophobic, so to be transported in our bloodstream, they are packaged into molecules called lipoproteins. They have a central core of the lipids, and the outer layer contains phospholipids, phospholipids, and apolipoprotein molecules. The apolipoproteins are special lipoproteins, special apolipoproteins in the outer layer of the lipoprotein, and they help sort of serve as targets for receptors when the lipoprotein gets to where it's going to go, and help with metabolism of the lipoprotein when they attach to those receptors. So the main lipoproteins that are present in our bloodstream are chylomicrons, VLDL, which is very low density lipoprotein, intermediate density lipoprotein, low density lipoprotein, and high density lipoprotein. You can tell by the names, the classification is based on the density. So the least dense are actually chylomicrons, which have the most triglycerides. Then there's a very low density lipoprotein, which has more cholesterol in it and less triglycerides. Intermediate density lipoprotein is actually intermediate between VLDL and LDL. It's not intermediate between LDL and HDL, which can cause some confusion. So it's actually intermediate low density lipoprotein, and it contains progressively more cholesterol and less triglycerides. LDL has the greatest amount of cholesterol, and HDL, which is the densest, has the most protein and less cholesterol. So those are the main lipoproteins that are present in the bloodstream, and we'll go over their metabolism in more detail here. The pathways of metabolism, there's two major pathways. There's the exogenous pathway, which is basically the metabolism of lipids that we take in our diet. And then there's the endogenous pathway, which is the metabolism of cholesterol and lipids synthesized by the liver. There's also a reverse transport pathway, which involves mainly HDL transporting cholesterol from tissues back to the liver. We'll start by going over this exogenous pathway of lipid metabolism, which basically goes over what happens to lipids that we ingest in our diet. So slightly complicated slide here, but it goes over the details very well. So when we eat lipids, cholesterol and triglycerides make their way to the small intestine in fat globules. And these fat globules have to be broken down. So they get broken down by the action of bile acid salts, which emulsify the fat globules into smaller particles called micelles. And then on these micelles, pancreatic lipase acts with the help of colipase and breaks down the triglycerides into free fatty acids and glycerol molecules, which are taken up by the enterocyte. The cholesterol itself is taken up by the enterocyte directly as well. There's a couple of drugs that act in this area. One is ezetimibe, which inhibits Niemann-Pick C1-like protein, which is a protein involved in the uptake of cholesterol in the enterocyte. And the other are bile absorption inhibitors, which increase the excretion of bile salts, and bile salts themselves contain cholesterol. So they interrupt the enterohepatic circulation of bile salts and result in increased excretion of bile salts and therefore increased excretion of cholesterol. So essentially, when these free fatty acids, glycerols, and cholesterol are taken up by the enterocyte, they're then packaged with apolipoproteins into molecules or into lipoproteins called chylomicrons. And these chylomicrons then make their way into the bloodstream. So the basics of it is that the lipids that we ingest, mainly triglycerides and cholesterol, are packaged into lipoproteins called chylomicrons that then make their way into the bloodstream. These chylomicrons will interact with HDL in the bloodstream and pick up different apolipoproteins as well. And these apolipoproteins help target the chylomicron to where it's going to go. The chylomicrons that are assembled in the intestinal mucosal cells carry triacylglycerol, cholesterol, fat-soluble vitamins, and cholesterol esters. The majority of the composition is triglycerides, which is close to 90% of the lipids in a chylomicron. Eventually, what happens to the chylomicron is because of the ApoC2, it interacts with an enzyme called lipoprotein lipase. So the chylomicron makes its way through the bloodstream, finds lipoprotein lipase because of that ApoC2. And lipoprotein lipase is an extracellular enzyme which is anchored by heparan sulfate to the capillary wall of most tissues, but predominantly in the adipose tissue, in the cardiac and skeletal muscle. Lipoprotein lipase is activated by ApoC2 on the circulating chylomicron particles, and it hydrolyzes the triglycerides into fatty acids and glycerol. And this fatty acids and glycerol is then used either for energy by muscles or stored in the adipose tissue. What's left of the chylomicron is called the chylomicron remnant, and this makes its way back into the bloodstream and eventually is uptaken by the liver. And that's the main link between the exogenous and the endogenous pathway, is the chylomicron remnant, which is taken up in the liver by LDL receptor-like molecules. Okay. So then that's, in a nutshell, that's the exogenous pathway. And what happens in the liver in terms of absorption, in terms of manufacturing cholesterol? In the liver, in hepatocytes, cholesterol is synthesized by the endogenous pathway, and it's synthesized using products of the Krebs cycle. We'll go over that in some detail, and it's an area where a lot of LDL lowering medications act as well. So it's important to know that, and I'll kind of talk about both things at the same time. So within the hepatocyte, you get citrate and acetyl-CoA from the Krebs cycle. Citrate is converted by an enzyme called ATP citrate into acetyl-CoA. Acetyl-CoA then becomes HMG-CoA, and it makes its way through the pathway to become cholesterol. This cholesterol is then packaged into VLDL molecules, gets secreted into the bloodstream, completes its journey to become LDL, which we'll talk about in some more detail. LDL makes its way into tissues and eventually is reuptaken by the liver by LDL receptors. These LDL receptors are then endocytosed, and they are acted on by a protein called PCSK9 to break down the LDL receptor. This is an important slide because apart from going over the production of cholesterol, it also goes over where a lot of LDL lowering drugs act. So the main drug that we use are statins, and they affect the rate limiting cholesterol synthesis, which is the action of HMG-CoA reductase. So statins inhibit HMG-CoA reductase, and they reduce the production of cholesterol. This leads to reduced cholesterol availability, which in turn leads to upregulation of LDL receptors, which leads to increased LDL uptake from the bloodstream and lower LDL in the bloodstream. Other drugs that can act here, number one here is bempedoic acid, which is a newer LDL lowering drug. We're still waiting outcomes data on that, but it has been shown to lower LDL and isn't expected to cause myopathy like statins. We talked about ezetimibe, which actually acts at the intestinal villi and reduces absorption through inhibiting the Niemann-Pick C1-like protein. And then two other classes of drugs. You guys are probably now aware of PCSK9 inhibitors. These are monoclonal antibodies that inhibit PCSK9 protein. So what that does is that it reduces the breakdown of LDL receptors, and that increases LDL receptors on the hepatocyte surface, and that leads to increased LDL uptake from the bloodstream. These are very effective drugs. They're subcutaneous injections that lower LDL generally about 50%. And sort of one of the newer drugs also out there is an mRNA inhibitor. So a drug called inclisiran, which actually inhibits the transcription of PCSK9 protein. It's a very exciting drug because it can be given every 6 months and also lowers LDL by about 50%. So that's also has been shown to lower LDL and is now in outcomes trials. So we've gone to a point where we can potentially give somebody a drug every 6 months that lowers their LDL by about 50%. And all of that is based on our understanding of cholesterol synthesis and the metabolism of LDL receptors and the uptake of LDL from the bloodstream. All right. So when this cholesterol is produced in the hepatocyte, it's again packaged with proteins into another lipoprotein called VLDL. So VLDLs are secreted directly into the blood by the liver as VLDL particles. And these particles contain an apolipoprotein called ApoB100. They obtain ApoC2 and ApoE from circulating HDL. And as the VDL passes through the circulation, triglycerides in it are degraded by lipoprotein lipase, causing the VLDL to decrease in size and become denser. So again, as VLDL passes through the circulations, its triglycerides are degraded by lipoprotein lipase. It starts to decrease in size, become denser, and eventually converts into intermediate density lipoproteins. The intermediate density lipoproteins interact with HDL with the help of an enzyme called CETP, and HDL transfers cholesterol into the IDL and takes some triglycerides, and you're eventually left with an LDL particle. The main function of LDL is to provide cholesterol to the peripheral tissues, or it ends up returning into the liver. So this LDL then goes to different organs and glands, such as the adrenal gland, the gonads, and it's used to make hormones or maybe incorporated into cell membranes. And the remaining LDL makes its way back to the liver. The unfortunate part of this story here is that some of the LDL ends up going into the arterial walls. And when that happens, the LDL can get oxidized, gets uptaken by macrophages, and can form foam cells. And these foam cells are pro-inflammatory, and they lead to the development of atherosclerotic plaque, which results in the clinical consequences of atherosclerotic cardiovascular disease. So again, coming back to the metabolism in the hepatocyte, LDL eventually makes its way back to the liver and is taken up by LDL receptors. And after being uptaken, the receptor complex is endocytosed. This is where PCSK9 also acts and can then break down the LDL receptor. If the PCSK9 is inhibited, then the LDL receptor gets recycled and therefore can go back and pick up more LDL molecules. So what about HDL? HDL is actually important in reverse cholesterol transport. It picks up cholesterol from the bloodstream, from blood vessels and tissues, but it also serves several other functions. So HDL is very protein rich, and it serves as a circulating reservoir for proteins like ApoC2 and ApoE, which are required for the receptor-mediated endocytosis of IDLs and cholesterol remnants. The main point here is that HDL is more complicated than just reverse cholesterol transport. It's also a reservoir of apolipoproteins. It can uptake unesterified cholesterol and helps in the esterification of cholesterol. And this kind of complicated nature of HDL may be why drugs that simply increase the quantity of HDL haven't really been shown to be that beneficial. And there's more interest within the lipid community for trying to figure out ways in which we can measure HDL function rather than just HDL quantity, specifically measure the reverse cholesterol transport function of HDL and then target drugs just to that function. Coming back to that slide we started with, hopefully we now have more of an understanding of the various pathways of cholesterol metabolism, particularly exogenous pathway, which involves the uptake of lipids from our diet, packaging into chylomicrons. The endogenous pathway, which involves the synthesis of cholesterol in the liver, packaging into VLDL, and then the journey into IDL, LDL, and then reuptake by the liver, or the unfortunate consequence of LDL getting deposited in blood vessels and leading to atherosclerosis, as well as reverse cholesterol transport by HDL, which can be beneficial, but HDL's function is a little more complicated than just the reverse transport pathway. I'll now move on to talking a little bit about what happens when things go wrong here. So, and I'll talk about one major dyslipidemia to start with, and that's familial hypercholesterolemia. The problem that happens in familial hypercholesterolemia is that the reuptake of LDL by LDL receptors is inhibited due to various genetic problems, most commonly within the LDL receptor itself. And this can lead to a condition called familial hypercholesterolemia. We see the heterozygous form of this most commonly in adults. The homozygous form is more of a pediatric condition because the cholesterol levels are so high that they end up having complications in the pediatric age group. Heterozygous familial hypercholesterolemia is associated with fairly high LDL levels, generally over 190. And it leads to the complications of premature atherosclerotic cardiovascular disease. It's more common than we used to think it was. It's an autosomal dominant condition, and its incidence is actually thought to be around 1 in 250. So if you think about that, 1 in 250 is common enough that you're going to see these patients and you're going to pick them up somewhat regularly. Some of the signs to look for heterozygous familial hypercholesterolemia is signs of peripheral cholesterol deposition. These can be in the form of xanthomas, which are cholesterol deposition in the tendons, commonly in the ankles, but can also be in the fingers and on the feet. You can have xanthelasmas, which are cholesterol deposition in the eyelids. And then you can have arcus senilis, which is cholesterol deposition within the eye itself. And when you see this in younger patients, it can be an indication of familial dyslipidemias. There's certain criteria you can use for heterozygous familial hyperlipidemia. This is the Simon-Boone diagnostic criteria. And basically, it's based on very high total cholesterol levels. You can have tendon xanthomas, genetic evidence of mutations, most commonly within the LDL receptor itself, but you can also have mutations in ApoB100 or PCSK9, a family history of premature coronary artery disease, or a family history of very high total cholesterol. And based on these criteria, you can classify a patient as possible or definite familial hypercholesterolemia. One of the interesting things about familial hypercholesterolemia is that it provides additional evidence on the role of cumulative LDL exposure in atherosclerotic cardiovascular disease. What I mean by that is that in patients who have very high LDLs and homozygous FH, you will start seeing that they cross the threshold for clinical cardiovascular disease very early, even in their teenage years, versus those that have heterozygous FH. So those that have homozygous FH have LDLs of 400 or more, generally. In heterozygous FH, it's around 190 or more, and they tend to cross the threshold later in their 30s, while patients without FH don't cross it until their 50s. And this is very strong evidence for LDL as or excessive LDL exposure as a cause of cardiovascular disease. This threshold can, of course, be shifted up or down by the lack of or the presence of other risk factors. Right. I'll move on now and talk about another dyslipidemia, and that is elevated lipoprotein little a. And that involves some degree of understanding of what LP little a is. So LP little a is a small LDL-like particle with an attached apolipoprotein A. And the unfortunate thing about it is that the attached apolipoprotein A makes this particle more atherogenic and more thrombotic. So LP little a elevations are associated with the risk of atherosclerotic cardiovascular disease, of thrombosis, and even anemia. recently been found to be associated with an increased risk of aortic stenosis. The increased risk of cardiovascular disease is now being more and more recognized in patients with high Lp(a). This was one study that showed that in the higher quintiles of patients with Lp(a) and a family history of premature coronary artery disease, there's a clear separation from lower quintiles in terms of both coronary heart disease and total atherosclerotic cardiovascular disease. How much that association is still somewhat debatable. So elevated Lp(a) in the most recent AHA guidelines is considered a risk modifier, but we're getting a much greater understanding about Lp(a), and in patients who specifically have very high Lp(a)s are at high risk, almost as close to a heterozygous familial hyperlipidemia. The guidelines differ as to who you should be measuring Lp(a) in, and as we learn more about it, we're probably going to have more clearer guidelines. The European guidelines, for example, say that you should pretty much check it in everybody once, just to rule out extreme elevations, while the American guidelines just consider it a risk modifier. There are some patients in which we should definitely be considering checking it. Those are definitely patients who have recurrent events despite statin therapy. Also, patients who don't respond as much to statin therapy in terms of LDL lowering as you would expect, and we'll talk about why that happens with Lp(a) too. One of the issues with Lp(a) so far is that we don't really have any specific therapies for it. So the general recommendations in patients with elevated Lp(a) is still to use LDL lowering therapies to reduce their overall risk. But there are some drugs and some very promising drugs who have reached the phases of outcomes trials, especially in secondary prevention, and we should be seeing them come to market in the next few years if those trials are positive. Right. I'll move on to another dyslipidemia, which is probably one of the most common dyslipidemias we actually see, and that's the dyslipidemia of insulin resistance. Insulin resistance plays a role in multiple areas within lipoprotein metabolism. So when you have insulin resistance, that leads to increased manufacturing of chylomicrons. It leads to increased breakdown of fat in adipose tissue and in muscles, which leads to increased free fatty acids. There's increased glucose coming into the liver, which, as we talked about from the Krebs cycle pathway, leads to increased production of VLDL, which gets then converted to LDL. So what you end up with is that you have increased chylomicrons, increased VLDL, increased LDL, and you have smaller and less HDL. So all of this promotes a more atherogenic milieu, and we'll talk a little bit more about that when we talk about the different testing and the atherogenic particles a little bit more. So I'm going to move on now to testing, and I talked about all the different lipoproteins. How do we test for this when we do a lipid profile on a patient? We don't generally actually measure the lipoproteins. What we actually measure is the amount of cholesterol within those lipoproteins. And so when we do a lipid panel, what we're checking to start with is the total cholesterol content from within all those lipoproteins. We can then separate out the HDL cholesterol. So you're left with the total cholesterol. You take out the HDL cholesterol, and what's left after that is your non-HDL cholesterol. The non-HDL cholesterol is actually a very good measure of the total cholesterol in all the atherogenic particles. So the atherogenic particles are your LDL, IDL, and VLDL. And your non-HDL cholesterol basically measures all the cholesterol that's present in these atherogenic particles, which is why non-HDL cholesterol is really considered one of the best markers of your overall risk status. Most risk calculators actually use non-HDL to calculate your risk scores. So non-HDL cholesterol is an excellent measure of atherogenic risk and your atherogenic cholesterol particles. You can go one step even beyond that and actually measure ApoB levels. So when we're talking about ApoB measurement, by lab test, we're talking about ApoB 100. And ApoB 100 is a molecule that's present on each atherogenic particle. So an ApoB measurement actually gives you the particle number of atherogenic molecules present in the bloodstream. It isn't used as often as non-HDL cholesterol because it's more expensive to measure it directly. It's also not as standardized. But if you're looking for a very precise measurement of risk status, you could go for an ApoB level. More commonly, though, we use non-HDL cholesterol. It's also important to recognize that in patients who have discordantly elevated non-HDL cholesterol, they're still at high risk. So we use LDL more as treatment targets, but in patients who have a discordantly elevated non-HDL, so generally you would think that the non-HDL should be about 30 milligrams per deciliter more than the LDL cholesterol. If it's more significantly elevated, then that patient is still considered at high risk because they still have a lot of atherogenic cholesterol molecules. And you'll see this discordant elevation more in patients with metabolic syndromes and insulin resistance. So it's important to look for, apart from just looking at LDL as therapeutic targets. Right, so you'll notice one thing that's missing from here is actually just the LDL cholesterol. So how do we get the LDL cholesterol from the measurements of the total cholesterol and then the HDL and non-HDL cholesterol? That's based on the Friedwald formula. So the LDL is actually reported as a calculated measure, which is based on the direct measurement of the total cholesterol, HDL cholesterol, and triglycerides. VLDL is then estimated as triglycerides over 5, and all of that is subtracted to give you the LDL cholesterol. So the calculated LDL is actually achieved by subtracting the HDL cholesterol and an estimate of the VLDL cholesterol from the total cholesterol number. And you can see that this actually has some assumptions built into there. But it is the most commonly used method to calculate LDL, and it's the method that's been used in most clinical trials as well. There is a different method that has been developed within the last 5 to 10 years, and that's the Martin-Hopkins method. It is considered a more accurate method. The National Lipid Association recently came out with a statement recommending it over the Friedwald method. The main difference is that instead of using 5 as a fixed factor, it uses a more variable approach and has different variables to divide the triglycerides by based on the triglyceride number. I don't think it's been as widely adopted yet, but it probably is going to be more widely adopted. If you have concerns about your calculated LDL, you can also check a direct LDL level. So when should you have concerns about your calculated LDL? It's if your triglyceride numbers are really high, then this equation doesn't hold. So generally you would think triglycerides over 300 to 400, you then need to check a direct LDL instead. Also at very low LDL levels, this equation doesn't hold. So you then need to check a direct LDL. We don't check direct LDLs in everybody because, again, it's more expensive. Also, direct LDLs aren't as standardized either, so that can lead to some issues as well. So what about fasting versus non-fasting lipid profiles? This has been an area of some debate as well. You can see within the calculated LDL cholesterol, triglycerides do play a role. And like we talked about from the exogenous pathway, you end up with more chylomicrons if you eat a fatty meal. And the chylomicrons contain a high amount of triglycerides. So definitely your triglycerides are affected by fasting versus non-fasting status. Your calculated LDL can also be affected if you have high triglycerides. The total non-HDL cholesterol, though, isn't affected as much. And the non-HDL cholesterol is more based on your endogenous cholesterol synthesis. So fasting versus non-fasting lipid profiles, a non-fasting lipid profile is actually a decent way to estimate the non-HDL cholesterol, which is the main thing that you're using for risk stratification. So as a screening test, you can use a non-fasting lipid profile. But as confirmatory tests, as targets for treatment, and if you end up with high triglycerides on the initial test, then you have to get a fasting lipid profile. Clinically, I tend to get fasting lipid profiles in everybody. It is not that difficult for my patients, but in a resource poor setting, it's reasonable to get a screening non-fasting lipid profile to assess their risk, and then get a fasting one if you need, or add on a direct LDL if you need. So to summarize, and I'll kind of skip between this slide and the last one so we can make sense of it. Your total cholesterol is the sum of all the cholesterol present in the lipoproteins. This includes VLDL, IDL, LDL, lipoprotein A, and HDLC. So I'll come back to this. The total cholesterol is basically the sum of the cholesterol in all the particles. Your non-HDL cholesterol is the total cholesterol minus the HDL cholesterol. The calculated LDL cholesterol, which we will sometimes refer to as LDL, is actually somewhat more complicated than that. The calculated LDL cholesterol ends up being the cholesterol in your ideal cholesterol plus the cholesterol in your LDL cholesterol plus the cholesterol in your lipoprotein little a's. While your direct LDL is the cholesterol in LDL cholesterol in LP little a. Where this plays a role, and it's being more recognized now, is that in patients with high LP little a, if you put these, like we talked about, statins don't really lower LP little a, they only affect LDL. So if you have a patient who has a high calculated LDL cholesterol, you put them on statins and they're not responding as much in terms of their LDL receptor, LDL reduction, or LDL cholesterol reduction, you should think about them having a high LP little a contributing to that. And it's reasonable to check an LP little a in those patients as well. All right, I'll move on to some of the primary dyslipidemias. So this is a commonly used classification for dyslipidemias. It's the Fredrickson classification. It's based on phenotypes. And it's essentially based on the phenotype of which lipoprotein and lipid fractions are elevated. So type 1 has elevated chylomicrons. Type 2A, which is the familial hypercholesterolemia, has increased LDL. Type 2B is familial combined hypercholesterolemia, so has increased LDL and VLDL. Type 3 is dys-beta lipoproteinemia, which has increased IDL. Type 4 is familial hypertriglyceridemia, which has increased VLDL. And type 5 is familial lipoprotein lipase deficiency, which has increased VLDL and chylomicrons. Apart from the primary dyslipidemias, I think it's also very important to recognize the secondary causes for dyslipidemias, particularly for triglycerides, but also for LDL. So things that can cause elevations in LDL and triglycerides are diet. For LDL, it's more of increased fat intake. For triglycerides, it can be alcohol consumption and high carbohydrate diets. Drugs are important to consider, I'd say, particularly for triglycerides. If you're taking estrogen, glucocorticoids, bile acid sequestrants, those can all play a role. In terms of diseases, secondary causes can include obstructive liver disease, nephrotic syndrome, and for triglyceride, for LDL elevation in particular, nephrotic syndrome is something, if you see somebody who's had a relatively normal LDL before and you see a bump, then it's recommended to check for protein excretion and to clinically look for nephrotic syndrome as well. Triglyceride elevation can also be caused by chronic kidney disease, nephrotic syndrome, and in the setting of sepsis. Certain metabolic disorders such as obesity and pregnancy can contribute. Hypothyroidism can cause LDL elevation. Uncontrolled diabetes is probably the most common cause of triglyceride elevation that we see. All right. Getting close to the end of my talk, and I'll talk a little bit about an approach to severe hypertriglyceridemia or chylomicronemia. Severe hypertriglyceridemia is most often multifactorial. So you most often see it in patients who have a genetic predisposition to high triglycerides, and then they have some kind of environmental factor, which was the second hit and it caused the severe elevation. And so we'll come back to these secondary causes of what you should look for. Most commonly, you'll see uncontrolled diabetes or metabolic syndrome, but also dietary excesses, obesity, all of that can contribute. Why that's important is that if you're able to identify that environmental trigger and take care of it, these patients can be some of the most rewarding because you'll see their triglycerides drop from the thousands to the hundreds, sometimes even into the double digits if they're compliant and if you're able to get rid of that environmental trigger. It's important to recognize that in patients who have very severe hypertriglyceridemia and chylomicronemia, the risks are a little different than those with moderate hypertriglyceridemia. When you have chylomicronemia, so when you have chylomicronemia, then you end up with these large triglyceride-rich molecules that are actually not necessarily atherogenic, but they can increase your risk of developing pancreatitis. With the chylomicrons, when they are very high in the bloodstream, can actually trigger pancreatitis by causing pancreatic lipase to activate within the pancreas. So chylomicronemia is associated with the risk of pancreatitis. Versus when you have more moderate hypertriglyceridemia, then you're trying to see there's an increased risk of atherogenesis, and you're trying to figure out if they have increased ApoB containing particles. So you want to look at the non-HDL cholesterol and assess their risk overall. When you have chylomicronemia and you have triglycerides in the thousands, then you're trying to focus on reducing the risk of pancreatitis. So you're aggressively treating the triglycerides, and you would recommend a very low-fat diet to try and reduce the chylomicrons. Versus when you have moderate hypertriglyceridemia, then your main concern is figuring out their ASC, their atherogenic disease risk, and trying to focus on reducing their atherogenic disease. I'm going to end with a couple of slides that aren't necessarily related directly to my talk, but I like sharing these slides with our fellows. Again, I'm going to zoom out a little bit and talk about prevention in general. This talk was focused really just on cholesterol. And sometimes when we focus too much, we kind of lose the bigger picture. And it's important when you're seeing patients in clinical practice to keep that bigger picture. And
Momin, we are running out of time.
Right.
So if you can wrap it up, please.
Sure. Last two slides. So it's important to look at all their risk factors. You know, if you have somebody and you're focusing on getting their LDL 70 versus 60 while their blood pressure is 190 and their A1C is 10, then it's also important to look at those other risk factors and try and work on them. And my last slide here, as what I see in our fellows sometimes is that we're really attracted to taking care of patients who are acutely sick. And because if we're able to turn them around, we see an immediate reward in that. But it's also important to keep your healthy patients healthy. In fact, I would argue that it's more important to keep your healthy patients healthy. You don't see that immediate reward in that, but the long-term reward you're getting is actually significant. And see, Christian Barnard was a heart transplant surgeon who performed the first human-to-human heart transplant. And he said that if I've saved the lives of 150 people by heart transplants, And if I had focused on preventive medicine, I might have saved 150 million. He was obviously a very confident person, and maybe he was overestimating what he could have done. But the sentiment is definitely there. You know, an ounce of prevention is worth a pound of cure, and I really appreciate this opportunity to talk about prevention. Sometimes when you get into the weeds of it, it can get a little boring. But if you understand the basics well, then you're really able to apply that knowledge and do a lot for your patients. That's all for me. Thank you so much.
Thank you. Excellent. So let's run the questions once again and see if how many people answered it. So Furkan, can you run the questions, please?
Sure.
Now that you know everything, you will have only 60 seconds to answer the questions, and before we have the panelists to answer it. It was an excellent talk. We enjoyed it. Have you posted the questions? Okay, so now we have the questions in front of us. "60 seconds to answer all the questions."
Assalamu alaikum.
Furkan, show the results, please. Yeah, Furkan, can you show the results, because we have to finish it up in 5 minutes?
Sure, sir.
And the correct answer after this.
Yes, sir. Correct answer is also visible.
Thank you. So, excellent talk. And if you can go to Amber Malik as an expert panelist to please unmute yourself and give your expert or comments.
Thank you very much, Professor Hafiz, for this excellent seminar today. It's a pleasure to listen to Momin, whose career we've been following since he joined Aga Khan and then left for America. And Momin, it was a great talk. It's really nice to hear from somebody who actually specializes in lipids, something that we check routinely and then mindlessly treat. So it's nice to be reminded of the basic physiology, pathology behind all the treatments that we are doing. I actually have a few points to ask Momin about some of the peculiarities that we see in our country, and maybe he may have an answer for that. You talked about heterozygous familial hypercholesterolemia. We see a lot of young people with advanced atherosclerotic disease, whom we do not classify into familial hypercholesterolemia. But and we think that all these young men and women who land with us for intervention with acute MIs, with advanced atherosclerotic disease, we send them for bypasses. You look at their coronary arteries and they are diffusely diseased within their 30s and 40s. So is this just our ethnicity for South Asians, or do we actually suffer from familial hypercholesterolemia as a nation? And sometimes they have family relatives who say that when I was 15, a young lady will tell you that her cholesterol was checked and it was 290 total cholesterol, LDL was high, and do we treat these people because there are no risk calculators for them, and what to do for them? So that's one of my questions to Momin, actually.
Before you answer, Momin, can I ask Asad to give his expert opinion, because we are running a little
Running out
late.
of time.
Yeah.
Assalamualaikum, Professor Hafizullah Saab, and thank you very much for inviting me to be the panelist. Momin, a fascinating talk. I don't think even during my USMLE days or my MBBS days, I went through this in that sort of detail. So amazing talk, and the way you summarized it was beautiful. Again, just like Professor Amber Malik, I have a couple of questions, but maybe I'll wait till the end. If there is time, I'll ask you. But congratulations, amazing talk, and great work that you're doing for our community.
Excellent. I think we, in the interest of time, I'm sorry, I mean, we could continue to communicate that there's another webinar taking place very shortly, starting by Dr. Khalda Sumro, which is based on Go Red. I think this was a fascinating talk, which raised a lot of questions. We all have access to Momin, and we will ask him this question, and we expect a reply from you. So from our side, we will sign off right now, because another talk is waiting exactly at 9:30, and Suhail is also asking us to wrap it up as soon as possible.
Professor,
all the best, sir. Thank you. What a
could,
fantastic talk.
If I could make a comment, I think it's a great talk and a great session. I think while the other panelists and some of the members go on to the next session, maybe you should allow the participants to listen to the questions which Momin would want to reply to and respond to. So if you could carry on with this session for a little longer, and the others can switch over to the other Zoom session, so that the participant can hear the responses to these questions. And I have a little comment that I was reading a study on the Arabs, in the Middle East, and they found that the highest predictor for heart disease was not high cholesterol, but it is low HDL and high triglycerides. And that is something which we tend to see in our population also. So maybe we are relying too much on the Western data as a predictor of heart disease, rather than doing our own study. And to be honest, we've done different studies, and some of them have supported that it's the low HDL and high triglycerides which tend to be a predictor of heart disease. Maybe that's a point I'd like to ask Momin to elaborate if we can. But for us, some of us who have to participate in the other session, we'd leave for that. But Professor Hafiz, I wish you'd continue this session so people can hear the responses to the questions and what Momin has to respond to. So grateful. Thank you very much. It's a pleasure to be part of this conference. Great. Thank you.
Thank you. So, Momin, you have 5 minutes to answer all these questions.
All right. Well, thank you. Those are some...
I'll quickly listen in and then move on to the next session.
Okay. Those are some interesting questions. I don't think I have answers to all of them, except that we definitely do need more data specific to our populations. And there's actually even studies in the US specific to South Asians going on in this study and other studies like that, because South Asians definitely have a higher risk of coronary artery disease. One of the factors is probably one that I touched on is Lp(a) that we don't check as much. It is more elevated in South Asians. It's probably one of the reasons a lot of South Asians also don't respond as much to statin therapies. So that's one of the things. Now, if you see a young patient that has a high LDL, then whether that they have heterozygous familial hyperlipidemia or if it's a polygenic dyslipidemia, they're still at high risk, and we should yes, be treating them. If there's an LDL over 190, they should be treating them, even in the pediatric age group. So yes, you should start treatment. You should start treatment early if there's a high LDL. In terms of risk factors, South Asians also have a bad metabolic profile in terms of insulin resistance. So yes, high triglycerides and low HDL, which lead to increased non-HDL cholesterol as well, are definitely atherogenic and do increased risk. So to answer all those questions together, there's probably a mixed profile which is different than Caucasians. So we need more data on the South Asian side. But it's likely to be partly insulin resistance and partly high Lp(a) and partly high just mixed dyslipidemias as well. Some of the basic principles are still going to apply though. So if you have a very high LDL, you should be treating it. You should be looking for elevated Lp(a) and insulin resistance. Looking dietary modification when you have high triglycerides and low HDL and increasing exercise. All of that is going to be helpful as well.
Thank you.
Overall, the risk status in South Asians is high enough that we should generally have a lower threshold to initiate treatment.
You see, young people in their 20s don't like to start medication. If they do start medication, they will leave it. You can't compel them to continue, and it's difficult to make them understand. Which is, but clearly, if somebody's motivated, you can help them out. But we have a lot of people actually who land with us with extensive coronary artery disease. Also, what would be your target? What drug would you then use for lipoprotein A if they do not respond to statins? If you think it's lipoprotein A.
It's at this point, it's just intensification of statin therapy. In the future, there may be more.
Awesome.
Thanks, Momin. I have to go on to the next meeting. So lovely talking to you. And before Dr. Khalda really sort of ostracizes me, I'd better join the seminar. Thank you so much.
Thank you. Asad, you have a point, and then you can wrap it up.
Momin, one question, which is, I think, for people, as you said, people who are more interested in dealing with acute pathologies. So we deal with a lot of STEMIs, non-ST elevation MIs and stuff. And one of the things that we do now, especially in Pakistan, because not a lot of people here in Pakistan go through regular checkups that we do in US. So their cholesterols are unknown. Obviously, we start them on statin therapy. But what is the right time for checking their LDL cholesterol? Should we check it at the time of an acute MI, or should we wait and check it in a few weeks? Because I read a few studies, and I know the basic pathophysiology. Something changes during an acute MI. I can't remember the exact mechanism, but apparently it's not very accurate when you're checking it in the middle of an acute MI or just after an acute MI.
That is true, but I would still check it once to develop to access a baseline. Eventually, regardless of what it is, every acute MI you're going to start on a statin, and then I generally check in about 2 months. You can say 6 weeks, 6 to 8 weeks, and that'll show that first outpatient 6 to 8 week LDL is really going to show you whether you're hitting your targets with the statins or not, and whether you should intensify or add non-statins. Having said that, so the difference is in a lot of the PCSK9 inhibitor trials were actually based on ACS patients who were mostly already on statins at that point. So that's probably different than the Pakistani population that you're seeing who probably aren't on statins and then are coming in with MIs. Plus, I'm not even sure if PCSK9 inhibitors are available in Pakistan, right?
They are not. They are. Yeah. So it leaves it to me to thank you, Momin, for an excellent talk. It was really the nitty gritty, and it was made so simple to understand. And I hope most of us understood it. And now probably we can ask same sort of things from our fellows as well. Many thanks to Farmivo for hosting it and for making it possible to happen. And I'm very grateful to all my panelists and Solat. It was a pleasure to listen to Momin, and thank you very much. In 2 weeks' time, we will have the next talk, and that will be what are the targets and how do we achieve those targets. So till that time, thank you very much. It was an excellent talk.